Hi, good morning, doctors. Today we are on our day 24 of our reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. We are at page number 478, starting with musculoskeletal problems, bone disorders today. Let's start reading. Osteogenesis imperfecta. It's an inherited condition with an autosomal dominant inheritance. We are reading, structural diseases are all mostly autosomal dominant, and several types are there, but all have an underlying problem with collagen metabolism resulting in fragile bones that break easily. Other features include lax joints, thin skin, blue sclerae, hypoplastic teeth, and deafness. Presentation varies according to severity, may be obvious at birth or present early with fractures. Less severe cases present later and may be mistaken for NAI. Mild cases may not present until adolescence with thin bones on X-ray and treatment is supportive. So can be obvious at birth. Less severe cases can be presented in the neonatal period, and later mild cases can present may not present until adolescent with thin bones on X-ray, and the treatment is supportive. Like they will be having blue sclerae, hypoplastic teeth, deafness. So all of these syndromic conditions you should suspect osteogenesis imperfecta. Osteopetrosis or marble bone disease. It's an inherited condition with autosomal dominant or recessive inheritance. Dominant form presents in childhood with fractures, osteomyelitis plus facial paralysis. Recessive form is more severe, causing bone marrow failure and death. Okay. Bone marrow transplantation has been tried but is of limited success. So dominant form, since only one allele is required, so it will present in childhood with fractures, osteomyelitis and facial paralysis. Paget's disease of the bone. Abnormal osteoclast activity causes accelerated disorganized bone remodeling, affecting 1 to 2% of the UK adults. 15% have a family history. Males more to female ratio is 3:1. Most common in the elderly, only a minority are symptomatic, affects just one bone in 1 in 3 cases. Presentation. Pain. Dull ache aggravated by weight bearing often remains at rest. Deformity, bowing of weight bearing bones, especially the tibia, the saber femur, and forearm. Usually asymmetrical frontal bossing of the forehead. Distinctive changes on the X-ray. Increased bone specific alkaline phosphatase. Normal calcium phosphate and PTH. Management. Refer to rheumatology, give analgesia, oral or IV bisphosphonates decrease the pain and long-term complications. Complications are pathological fracture, osteoarthritis of the adjacent joints, high output cardiac failure, hydrocephalus or cranial nerve compression leading to neurological symptoms. There will be multiple cranial nerve problems. Deafness, spinal stenosis, bone sarcoma, rare 1.1 to 1.15%. So the problem here is there will be an abnormal osteoclastic activity. So there will be excessive bone resorption, and then again the body is going to put that all to the calcium back again. Because there will be compensation from the body, there will be increased calcium, normal calcium phosphate and high PTH. Okay. Normal calcium phosphate and PTH they're saying. Okay, and then what happens is when there is high turnover is there and the body is working so hard, so there will be high output cardiac failure, and then whenever this osteoclastic activity is accelerated, again bone formation is taking place, there can be a hydrocephalus or any cranial nerve compressions because of this remodeling which is taking place in the body. That's why it will cause neurological symptoms, either deafness, spinal stenosis or bone sarcoma. which can be rare. Osteomyelitis. Infection of the bone may spread from the abscess or following surgery after no primary site is often no primary site is found. More common in those with diabetes, sickle cell disease, impaired immunity, and poor living standards. Organism involved is Staph aureus, Streptococci, E. coli, Salmonella, Proteus, and Pseudomonas species, and tuberculosis of the bone. Presentation with pain, unwillingness to move the affected part, warmth, effusion in the neighboring joints, fever, and malaise. Blood cultures are positive in 60% of the cases. Raised ESR, CRP, and increase in white cell count is present in osteomyelitis. Management. Refer suspected cases for same-day orthopedic opinion. Diagnosis is confirmed with imaging, example MRI or bone scan. X-ray changes can take days to appear. Treatment is with IV, then PO antibiotics more than 6 weeks and surgery to drain the abscess. Complications: septic arthritis, pathological fracture, deformity of the growing bone, and chronic infection. Treatment is with IV and then PO antibiotics. More than 6 weeks treatment you should give for osteomyelitis. And surgery to drain the abscess. Complications: septic arthritis, pathological fracture, deformity of the growing bone, and chronic infection. Same day orthopedic opinion if you're suspecting septic arthritis. Chronic osteomyelitis occurs after delayed or inadequate treatment of acute osteomyelitis. Signs: there is pain, fever, discharge or pus from the sinuses, follows a relapsing and remitting course over years, needs specialist management. Referral guidelines for suspected sarcoma. This is sarcoma. Refer for an immediate X-ray any patient with suspected spontaneous fracture. If the X-ray indicates a possible bone cancer, refer urgently. Possible bone cancer, refer urgently. It is normal but symptoms persist, follow up or request repeat X-ray and bone function test or referral. So if your X-ray is indicating a possible bone cancer, then you have to refer urgently. And if your X-ray is normal but symptoms are persisting, follow up and or request repeat X-ray or a bone function test and or referral. Refer urgently. So that was refer immediately for X-ray if there is spontaneous fracture. Refer urgently if a patient presents with a palpable lump that is more than 5 centimeters in diameter, increasing in size, deep to the fascia, fixed or immobile, painful lump and recurrence after previous excision. If a patient has a HIV, consider Kaposi sarcoma and make an urgent referral if suspected. Urgently investigate. Increasing unexplained or persistent bone pain or tenderness, particularly pain at rest and especially if not in the joint, or an unexplained limp. So when you have to investigate urgently is persistent bone pain, tenderness, particularly pain at rest, especially not in the joint, and unexplained limp. In older patient, metastasis, myeloma or lymphoma as well as sarcoma should be considered if there is persistent bone pain. Sarcoma. Cancer of the bone or connective tissue. 2,300 patients per year are diagnosed with sarcoma in the UK and causes 1,000 deaths. There are two peaks of incidence, one in teenagers, another one in old age. 5 types of sarcoma account for more than 80% of tumors. Osteosarcoma and the Ewing's family of tumors present with aching bone pain. There's aching bone pain, there's swelling plus a pathological fracture. If X-ray is normal but symptoms persist, consider checking the bone function test and re-X-raying and discussing with the patient for specialist referral. Treatment involves surgery and chemotherapy. Overall 5-year survival is 50 to 80%. Adult soft tissue sarcoma of the limb or trunk, usually present with a palpable lump. The most common tumors are leiomyosarcoma, liposarcoma, and synovial sarcoma, treated with surgery plus radiotherapy. High-grade tumors, chemotherapy is reserved for palliation only. So, radiotherapy and surgery are the key in soft tissue sarcomas of the limbs. Whereas in bone sarcomas, involves surgery and chemotherapy. Osteosarcoma and Ewing sarcoma, the treatment will be surgery and chemotherapy. Whereas in adult soft tissue sarcoma, surgery and radiotherapy is more preferred option. Kaposi's sarcoma, you will see in page 722. Intra-abdominal sarcoma. It usually presents late, often arises in the retroperitoneum. If possible, surgery is the main treatment. Local relapse is common and often not responsive to cytotoxic therapy. Intra-abdominal sarcoma usually presents late, often arises in the retroperitoneum. If possible, surgery is the main treatment. Local relapse is common and often not responsive to cytotoxic therapy. Rhabdomyosarcoma originates from the striated muscle. Presence usually in children less than 2 years with a lump. Response to intensive multimodal therapy. Outlook is generally good, more than 60% long-term survival. So page number 480, we are here at rickets and osteomalacia. Vitamin D deficiency causes rickets in children and osteomalacia in adults. The body needs near about 10 micrograms of vitamin D per day to maintain a healthy bones. The body makes its own vitamin D when sunlight falls in the skin in the summer months, but a diet with adequate vitamin D is needed to maintain the supply in winter, especially for people who do not get out of for cultural or religious regions are completely shielded from the sun by their clothing. Clinical features of rickets: bone pain and tenderness, arms more in the arms, the legs, the spine and the pelvis. Skeletal deformity: bow legs, pigeon chest, forward projection of the sternum, bow legs, pigeon chest, forward projection of the sternum, rachitic rosary or enlarged ends of the ribs, asymmetrical odd-shaped skull due to soft skull bones, spinal deformity, kyphosis or scoliosis, and pelvic deformities. Pathological fractures can be one of the presentation. Dental deformities: delayed in formation of the teeth, holes in the enamel or increased cavities, muscular problems, progressive weakness, reduced muscle tone, muscle cramps, impaired growth, short stature can be permanent. Clinical features of osteomalacia: bone pain, diffuse particularly in the hips, muscle weakness, pathological fractures, low calcium levels. Causes: perioral numbness, numbness of the extremities, hand and feet spasms or arrhythmias. Causes and management: dietary deficiency of calcium less than 30 nanomoles of vitamin D less than 30 nanomoles per liter. particularly in children with pigmented skin in northern climes. Give vitamin D and calcium supplements. Age-related deficiency. Vitamin D metabolism deteriorates with age, and many more than 80 are deficient. Consider giving vitamin D 800 international units per day to all elderly more than 80 years. Secondary rickets or osteomalacia. Due to other disease like malabsorption, liver disease, renal tubular disorders, and chronic renal failure. So conditions are malabsorption will not let vitamin D get absorbed, liver disease, and renal tubular disease or chronic renal failure will prevent the metabolism of vitamin D to 1-hydroxy and 3-trihydroxy vitamin D. Treat underlying cause and supplement the calcium and vitamin D as needed. Vitamin D dependent rickets. It's a rare autosomal recessive disorder. It's a metabolic disorder, so it's an autosomal recessive inherited disorder resulting in an enzyme deficit in the metabolism of vitamin D. Refer for specialist care treated with vitamin D calcium supplements. Hypophosphatemic rickets or vitamin D resistant rickets. X-linked dominant trait. So this is an X-linked dominant trait resulting in decreased proximal renal tubular absorption of phosphate. Parathormone and vitamin D levels are normal. So PTH and vitamin D levels are normal because they are PTH level is determined by calcium levels, and vitamin D's are normal. A specialist management is needed. Treatment is with phosphate replacement plus calcitriol. Okay, hypophosphatemic rickets or vitamin D resistant rickets. So when you're giving vitamin D also it is not getting cured, then it could be because of phosphate deficiency. And vitamin D dependent rickets is because of autosomal inherited disorder in metabolism of vitamin D. That's why you have to give the form metabolite like vitamin D3 you have to give, and calcium supplements, not vitamin D supplements, because it's not getting metabolized in the body. So dietary sources of calcium and vitamin D is listed in table 14.6. Approximate vitamin D content of common foods. Margarine, a 10 gram serving is 0.8 micrograms of vitamin D. Eggs, one size 3, 1.1. Cheese, 60 grams has 0.2, milk 0.051151 pint, that is 0.15 liters, that is 150 ml is 1/4 of a pint is 0.05, very less. Butter 10 grams has 0.1, fortified cereals have 0.5, herring 16.5, herring is a fish. Okay, herring per 100 grams of serving has 16.5 micrograms of vitamin D. That's very good. Mackerel 100 grams 8, sardines 100 grams 7.5, tinned tuna 100 grams 4, tinned salmon 100 grams 12.5, kipper 100 grams 13.5. So mostly the fishes have a high content of vitamin D in a 100 gram serving. Recommended daily intakes from birth to 50 years is 5 micrograms, and 50 to 70 years is 10 micrograms, and more than 70 years is 15 micrograms. Approximate calcium content of common foods. So we were seeing the vitamin D content, and now this is the calcium content. Whole milk has 220 milligrams of calcium per pint, and semi-skim milk, one third pint, has 230 milligrams. It's also good. So nearly as good, both of them. So whether you drink whole milk or semi-skim milk, the calcium content remains same. Hard cheese is 190, cottage cheese is 80, low-fat yogurt is 225. So even low-fat yogurt has the same calcium content you're desiring as normal fat yogurt. Sardines including the bones, so you have to eat the bones also, then it is 310. Brown in or white bread 100, whole bread 55, baked beans 60, boiled cabbage is 40. So milk has relatively more content of vitamin calcium, and then comes the cheese and the yogurt, milk products, and then sardines. Recommended daily intake at birth to 6 months is 210 milligrams. Okay, 7 months to 1 year is 270 milligrams. 1 year to 3 years is 500 milligrams. 4 years to 8 years is 800 milligrams of calcium per day. And 9 years to 18 years is 1300 milligrams of calcium per day. 19 years to 50 years is 1000 milligrams per day, and more than 50 years is 1200 milligrams per day. So the calcium requirement is increasing exponentially from birth till more than 50 years. 482. So depending upon which age group we are in, from 19 to 50 it is near about 1000 milligrams of calcium. So are you taking 1000 milligrams of calcium daily? You should be taking. 482. Osteoporosis. The lifetime risk of osteoporotic fractures 1 in 3 in females and 1 in 5 in males. More than 2 lakh fractures in the UK per year in the UK. The main morbidity and financial cost of osteoporosis related to hip fracture, where the incidence increases steeply over 70 years. Treatment aims to prevent the fracture. Definitions are T-score. What is osteoporosis? Is defined by the T-score. Compares the bone mineral density of the subject with a young adult mean age 30 years. Osteoporosis is defined as a bone mineral density more than 2.5 standard deviations below the young adult mean, T-score of less than minus 2.5. There is 2 to 3 times increased relative risk of fracture for each standard deviation reduction in BMD. Osteopenia is diagnosed if T-score is between minus 1.1 and minus 2.5. Z-score compares the BMD of a subject to an age-matched normal control, that is, the measures whether the BMD is normal for a particular age and cannot be used to diagnose osteoporosis or osteopenia, but may be useful in young patients to predict osteoporosis risk for the future. So Z-score, where do you use? In young patients to predict osteoporosis risk for the future, whereas T-score you will be using for diagnosis of osteoporosis. Causes: osteoporosis may be primary or secondary to other medical conditions. Endocrine causes of osteoporosis are hypogonadism, premature menopause, anorexia, androgen blockade, taking aromatase inhibitors, hyperthyroidism, hyperparathyroidism, hyperprolactinemia, Cushing's disease, and type 1 diabetes. So these are 4 hyper conditions related to your thyroid and parathyroid, prolactin and cortisol, and hypogonadism. These 5 conditions, endocrine conditions, along with type 1 diabetes, will cause osteoporosis. So GI causes of osteoporosis are: there are many malabsorption disorders like celiac disease or other causes of malabsorption like inflammatory bowel disease, chronic liver disease, or chronic pancreatitis. Rheumatological causes are rheumatoid arthritis and other inflammatory arthropathies. Other causes are immobility, multiple myeloma, hemoglobinopathy, systemic mastocytosis, cystic fibrosis, COPD, CKD, and homocystinuria. So immobility is one cause of osteoporosis, multiple myeloma, hemoglobinopathies, systemic mastocytosis, cystic fibrosis, COPD, CKD. We know why, because CKD there is no metabolism of vitamin D, and homocystinuria are the causes. Fragility fracture. Fracture sustained falling from less than standing height includes vertebral collapse, may not be as a result of fall. Previous fracture is a risk of future fracture. Common fractures are hip associated with increased mortality, wrist fracture, Colles fracture, osteoporotic vertebral collapse causes pain, decrease in height, and kyphosis. Pain can take 3 to 6 months to settle and requires a strong analgesia. Calcitonin is useful for pain relief for 3 months after a vertebral fracture if other analgesics are ineffective. Predicting fracture risk. Two validated fracture prediction tools are available: FRAX and Q-fracture. Q-fracture does not require the bone mineral density measurement. FRAX can be performed without the bone mineral density measurement. Both provide information on 10 years possibility of a hip or other osteoporotic fracture, case finding and further actions. Figure 14.6. Bone mineral density measurement. X-rays cannot be used to measure the bone mineral density but are useful if vertebral fracture or metastasis is suspected. Hip and lumbar spine bone mineral density is measured using dual energy X-ray absorption absorptiometry DEXA. Do not request without prior use of risk prediction tool FRAX, without BMD measurement or a Q fracture. So you have to either measure a FRAX without BMD and a Q fracture, and then you have to advise for a DEXA, not before that. Glucocorticoid use. Steroid use is a risk factor for osteoporosis. Minimize the steroid dose. For patient taking oral high dose inhaled steroids, oral or high dose inhaled steroids more than 3 months, or frequent courses of steroids in addition, add bone protection agent or a bisphosphonate for patients more than 65 years or with a history of fragility fracture. Refer patients less than 65 years without history of fragility fracture for DEXA scan and add a bone protection agent if T score is less than 1.5. So if age is, so this is a flow chart for use of fracture risk prediction tools or FRAX. So here, if age is less than 50 years and there is any major risk factor for osteoporosis, example previous fragility fracture, current or regular glucocorticoid use, untreated premature menopause, prolonged amenorrhea, new celiac disease, no. In that case, low risk, do not assess any further. Or yes, in this case, yes, age is less than 40 years with a history of multiple fragility fractures, major osteoporotic fracture or high dose glucocorticoid use. If yes, then intermediate risk, check the bone mineral density and recalculate the FRAX incorporating BMD result. Again, another scenario, female age 50 to 64 years or a male age 50 to 74 years. So in this case, if there is a family history of hip fracture, history of falls, previous fragility fracture, low BMI, less than 18.5 kg per meter square, smokes more than 10 cigarettes per day, alcohol intake more than 4 units per day, glucocorticoid use current or frequent past, other secondary causes of osteoporosis is present, age 50 to 64 years or age 50 to 74 in males, and any of these are present, no, then low risk, do not assess any further, and high risk, yes, then assess the 10-year fracture risk using FRAX without a BMD or a Q fracture, and if the 10-year fracture risk is high risk, treat with bone protection, and if 10 years fracture risk is low risk, then recalculate risk after 2 years or risk factors if the risk factors change. Okay, and if there's an intermediate risk, check the BMD and recalculate FRAX incorporating the BMD result, and then if it's a low risk, again you have to calculate risk after more than 2 years, or this is the same thing, if it's high risk, then treat with bone protection, that is bisphosphonates in age 50 to 64 years. Again, age 65 to 84 or age 75 to 84 years are, you need to assess the 10-year fracture risk using FRAX or Q fracture and then give bone protection if high risk. Age more than 85, use clinical judgments to assess fracture risk. If risk is high, start bone protection treatment without further assessment. So more than 85, no need to assess FRAX score or Q fracture score. Just treat them with bisphosphonates. If clinically you assess that they are high risk for fracture. 84, page number 484, treatment options for osteoporosis. Lifestyle advice, provide to all at-risk patients adequate nutrition and maintain body weight so that BMI is more than 19 kg per meter square and adequate intake of calcium and vitamin D. Give calcium or vitamin D supplements to postmenopausal women with dietary deficiency. Also consider if on long-term steroids, more than 80 years, housebound or institutionalized. So for very lean people, you have to give adequate intake of calcium and vitamin D, and then give calcium vitamin D for post-menopausal women with dietary deficiencies. Also, if on long-term steroids, 80 years, more than 80 years or institutionalized. Regular exercise, weight-bearing activity more than 30 minutes per day decreases the fracture rate. Stop smoking. Women who stop smoking premenopause have a 25% decrease in fracture risk rate post-menopause. Decrease alcohol consumption to less than 14 units per week in both males and females decreases the fracture risk. So obesity is a protective factor for osteoporosis. Osteopenia. If T-score is between -1 and 2.5, provide lifestyle advice. Repeat DEXA scan in 2 years. Bisphosphonates. So when your T-score is between -1 and 2.5, you are not giving them any bisphosphonates or bone protection. Bisphosphonates, when do you give bisphosphonates? Alendronic acid 70 milligrams once weekly. Reduction in bone loss and fracture rate. Mainstay of treatment for osteoporosis. Avoid if severe CKD. If there is severe CKD or a woman of childbearing age, because there is a possibility of teratogenic effects. Instructions for use. Take on an empty stomach first thing in the morning, more than 30 minutes before food and other medication. Take in an upright position, wash down with plenty of water. Sit upright for 30 minutes after taking. Why? Because it has complications. Osteonecrosis of the jaw is a rare complication of bisphosphonate therapy, IB preparation more than PO, causes or non-healing gum lesions. Causes non-healing gum lesions. Treatment is with surgical excision of the affected bone. Okay. Risk of osteonecrosis increases after dental work. Advise patients to have a dental checkup and necessary dental work done before starting bisphosphonate treatment and report any oral symptoms when on treatment to the dentist. Atypical femoral fractures, prolonged bisphosphonate treatment, more than 5 years, over suppression of bone turnover and increased bone fragility is the reason for atypical femoral fractures. The acute subtrochanteric or mid-shaft femoral fractures are most common. A drug holiday of 1 to 5 years has been proposed for low-risk patients after 5 years and follow local guidelines. Denosumab, a 60 mg subcutaneous injection every 6 months. Monoclonal antibody that decreases the osteoclast activation and decreases the bone resorption. For postmenopausal osteoporosis, when bisphosphonates are contraindicated or not tolerated and severe osteoporosis is present, then you give them denosumab. You can be used for women with severe CKD, because CKD is a contraindication for bisphosphonates. Correct the hypocalcemia before starting the treatment with denosumab. May cause osteonecrosis of the jaw. Again, can cause osteonecrosis of the jaw. So even before alendronate therapy, you have to correct the calcium and vitamin D deficiencies. Raloxifene 60 milligrams OD is a selective selective estrogen receptor modulator SERM. Use if previous fragility fracture is present, bisphosphonates are not tolerated or contraindicated, or there is an unsatisfactory response to bisphosphonate, further fracture or a decrease in BMD after 1 year of treatment. Not recommended for primary prevention of osteoporotic fracture. Avoid if past history of DVT or PE is present, cholestasis, endometrial cancer or undiagnosed vaginal bleeding. Hormone replacement therapy postpones postmenopausal bone loss and decreases fractures. Optimum duration of use is uncertain, more than 5 to 7 years, but benefit disappears less than 5 years after stopping. Increase in breast cancer and cardiovascular risk limits the use. Hormone replacement therapy postpones postmenopausal bone loss and decreases the fractures. Optimum duration of use is uncertain, more than 5 to 7 years, but benefit disappears in less than 5 years after stopping. So, increase in breast cancer or cardiovascular risk limits the use of hormone replacement therapy. So NICE guidelines in 2015, premature menopause. Hormone replacement therapy or COC is recommended for prevention of osteoporosis until women reach natural menopause age. So you're not giving them hormone replacement therapy is not advocated for osteoporosis. It is only advocated to prevent osteoporosis until women reach natural menopause age, not after postmenopause. 51-year-old, more than 51 years, hormone replacement therapy should not be considered first-line therapy for long-term prevention of osteoporosis. HRT remains an option where other therapies are contraindicated, cannot be tolerated, or if there is lack of response or risk or benefit should be carefully assessed. So the other therapies that can be used is bone protection with bisphosphonates, denosumab, or raloxifene. Teriparatide, third line, it's a third line treatment. It's not first line treatment. It's a third line treatment for postmenopausal women and a second line treatment for men with past history of fragility fracture if other treatments are not tolerated or ineffective and specific T-score clinical criteria are met. Given by daily injection, maximum duration of use is 18 months only. Consider referral for consultant initiation if other treatment options are exhausted. So this is for patients with past history of fragility fracture and other treatments are not tolerated. In that case, you can consider teriparatide as a third line in postmenopausal women. So first line was bone protection, second was hormone replacement, and then is teriparatide. Osteoporosis in men. Currently, only bisphosphonates and teriparatide are recommended for treatment in osteoporosis in men. Monitoring. There is no consensus about duration of treatment for osteoporosis or monitoring of bone mineral density during treatment. Circumstances in which repeat DEXA scan might be necessary include a fragility fracture on treatment, if considering a treatment change, when considering restarting therapy after a drug holiday. Referral. Consider referral to an appropriate specialist. If another cause of fragility fracture is suspected like metastasis, urgent referral, fragility fracture on treatment, routine referral, unusual presentation of osteoporosis, example in premenopausal women, routine referral, for consideration of treatment with IV bisphosphonate, denosumab or teriparatide, routine referral. Further information is given in the following websites. Osteoarthritis. Osteoarthritis is the most important cause of locomotor disability. It is used to be considered wear and tear of the bone or cartilage of synovial joints, but is now recognized as metabolically active process involving the whole joint. Example: cartilage, bone, synovium, capsule, and muscle. So it's a metabolically active process of wear and not only wear and tear of the bone, cartilage, or synovial joints. The main reason for patients seeking medical help is pain. The level of pain and disability are greatly influenced by patients' personality, anxiety, depression, activity, and often do not correlate well with the clinical signs. Risk factors are increased age, that is uncommon in less than 45 years, females more than males in Black and Asian populations, genetic predisposition, obesity, abnormal mechanical loading of the joint, instability, poor muscle function, poor instability, joint instability, poor muscle function, post-meniscectomy, certain occupations like farming, etc. Symptoms and signs: joint pain plus stiffness, synovial thickening. So there is joint pain associated with stiffness, there is synovial thickening and deformity, effusions, crepitus, muscle weakness, wasting, and reduction in function at that joint. Most commonly affects the hip, the knee, the base of the thumb. Okay, the base of the thumb is also a common site for osteoarthritis. Typically, exacerbations last weeks to months. Nodal osteoarthritis with swelling of the distal interphalangeal joints. Distal DIP is Herberdens nodes, has a familial tendency. Proximal interphalangeal joints is Bouchard's nose, and distal interphalangeal joint swelling is Herberdens nose. BH. HP. Investigations. X-rays may show reduction in joint space, cyst and sclerosis in the subchondral bone plus osteophytes. There is joint space reduction, there will be cyst, sclerosis in the subchondral bone, and osteophytes. Osteoarthritis is common and may be coincidental finding. Exclude other causes of pain. Check FBC's ESR if inflammatory arthritis is suspected. Common and maybe a coincidental finding. Exclude other causes of pain. Example, check the FBCs and ESRs. If inflammatory arthritis is suspected, normal or mildly increased in osteoarthritis, ESR more than 30 suggests rheumatoid arthritis or psoriatic arthritis. So, maybe a coincidental finding only. Management of osteoarthritis in primary care. Employ a holistic approach. Assess the effect of osteoarthritis on the patient's functioning, quality of life, the occupation, the mood, the relationship, and leisure activities. Formulate a management plan with the patient that includes self-management strategies, effects of comorbidities, and a regular review. Information and advice. Give information and advice on all relevant aspects of osteoarthritis and its management. Arthritis Research UK produces a range of leaflets for patients. Use the whole multidisciplinary team example. Refer to physiotherapists for advice on exercises, strapping and splints. OT for AIDS. Chiropractist for foot care and insoles. Social worker for advice on disability benefits and housing. And orthopedics for surgery for if significant disability or night pain is present. So you are referring to an orthopedics only for surgery or if a significant disability or night pain is present. For rest everything you have to either suggest a physiotherapy or OT-aids or chiropractist or a social worker. Decrease the load on the joint. Weight reduction can decrease the symptoms and may decrease the progression of knee osteoarthritis. Using a walking stick in the opposite hand to the affected hip and cushioned insoles trainers can also help. Exercise improving muscle strength, decreasing the pain and disability. Example, walking for osteoarthritis of the knee, swimming for osteoarthritis of the back and hip, but may make neck worse. Okay, so exercising for improving the muscle strength here. Um, you need to walk for OA knee and swim for OA of the back and hip, but may make the neck worse. Cycling for osteoarthritis of the hip and osteoarthritis of knee, but may worsen patellofemoral osteoarthritis. Refer to physiotherapy for advice on exercises, especially isometric exercises for less mobile. Pain control. Use non-pharmacological methods first. Activity, exercise, weight loss, footwear modification, walking sticks, tents, local heat and cold treatments. So you have to give physiotherapy first. Regular paracetamol 1 gram QDS is the first line drug treatment for all osteoarthritis or topical NSAIDs for knee or hand osteoarthritis only. Topical NSAIDs have less side effects than oral NSAIDs, more acceptable to patients. Use opioids, oral NSAIDs or COX-2 inhibitors as second line agents in addition to or instead of paracetamol. Use the lowest effective dose for the shortest possible time. Co-prescribe a proton pump inhibitor, example omeprazole with NSAIDs if taken for more than 1 week. Low dose antidepressants, example amitriptyline 10 to 75 milligrams nocte, are useful adjunct therapy especially for pain causing sleep disturbance. Capsaicin cream can be helpful for knee and hand osteoarthritis only. Aspiration of joint effusions and joint injections can help in exacerbation. Some patients respond well to long-acting steroid injections. It may be worth considering a trial of a single treatment. Hyaluronic acid knee injections are not recommended by NICE. So many patients will come to you asking for hyaluronic acid treatments in osteoarthritis. Complementary therapies. 60% sufferers from OA are thought to use CAM. That is example complementary alternative medicine, copper bracelets, acupuncture, food supplements, dietary manipulation. There's a good evidence of chiropractic and osteopathy or osteopathy can be helpful for back pain, but otherwise evidence of effectiveness is scanty. Advise patients to find a reputable practitioner with accredited training who is a member of recognized professional body and carries professional indemnity insurance. Other drugs or supplements. Glucosamine. It is controversial whether glucosamine modifies osteoarthritis progression. It is available over the counter but not recommended by NICE. Strontium granulate decreases the progression of osteoarthritis, decreases the pain and increases the mobility. Yeah, definitely it does. Place in osteoarthritis management is yet to be determined, but it definitely helps with decreasing progression, decreasing the pain and increased mobility. Psychological factors. That means NICE doesn't recommend it. Have a major impact on a disability from osteoarthritis. Education about the disease, emphasis that it is not progressive in most people is important. Seek depression and anxiety with screening tools. Treated as needed. Refer to rheumatology to confirm the diagnosis. If coexistent psoriatic arthritis mimics osteoarthritis, can be missed by radiologists. Rule out secondary osteoarthritis. Example could be a pseudocoat or hemochromatosis if young osteoarthritis or distribution is present. If joint injection is thought worthwhile but you lack expertise or confidence to do it. If joint injection is thought worthwhile but you lack confidence, then you have to refer to rheumatology. So to orthopedics. If symptoms are severe for joint replacement, refer as an emergency if you suspect joint sepsis. Our next topic is rheumatoid arthritis. This we will continue tomorrow. That's all for today. Thank you. Have a good day.